Computer. All right, we are recording. You can start whenever.
Okay, so I will. So this is Sanjeev Basu from Epidemiology and Biostatistics from the School of Public Health. So I want to thank Sage Kim for agreeing to do this presentation in a really short notice. So the way we are going to do this presentation is Sage is going to present for the first part, most part, and then I'll do a small presentation towards the end. If you have any questions, you can send a chat message, and we'll try to answer it as possible. So I'll let Sage start. So Dr.
Okay.
Kim.
All right. So I'm gonna try share screen. So let me know if it works. Okay.
Okay.
How about that?
Yes.
Okay. Cool. All right. Hi everyone. I'm Sage Kim. I'm an associate professor, health policy and administration. I really appreciate this opportunity to connect with all of you. So I'm going to share with you what I've been doing since the beginning of March in relation to COVID crisis. I just have to say, Sanjeev approached me Wednesday night, so this is really difficult sort of task to compile everything, and I realized that I can't really talk to you all the things that I feel important to share. Not going to be in this presentation, but I'll be very happy to connect with you individually. So I want to talk to you about the role of data in emerging response and policy decisions mainly today. All right, so there are close to 26,000 confirmed cases in Illinois, and of those, over 18,000 cases are in Cook County, which is close to 72% of Illinois cases, and over 10,000 cases are in Chicago, which is 42% of Illinois and 58% of Cook County cases. So initially, Dr. Jiwan Sun and I sort of estimated the real cases might be over 190,000 in Illinois, and as of last night, we just did over 122,000 tests. So it's testing is extremely slow, considering what might be out there. So the confirmed cases only report only those people who could actually get tested. All right, so here's the death. Also, we can see, the cases and deaths are highly clustered in Cook County and Chicago. But if you look at the proportion of Cook County confirmed cases and deaths, that's actually occurred at sort of a relatively greater frequency outside of Cook County compared with the confirmed cases reported. So Cook County accounted for 72% of confirmed cases of Illinois, but 67% of death. So, I mean, there are probably many reasons for this, but one issue that we need to pay attention might be hospital capacity. By far, we know healthcare facilities are clustered in Chicago, and we may be seeing the effect of poor access to advanced COVID cases, COVID care outside of Cook County, sort of affecting the death rate. I was talking to Maya Square people yesterday, and they say U of I capacity is at just over 75%, and Northwestern hospitals at 80%. But we don't really know facilities outside of Cook County. So in response to the current crisis, Illinois issued a series of executive orders going back to March 9th, when Illinois issued a state disaster declaration. Within a week, all large gatherings are canceled, and on March 16th, all schools were closed. March 20th, the shelter-in-place order was issued, and on April 1st, all social distancing policies were extended to the end of April. So the question is, are these executive orders actually making a difference? It's still early, but just looking at the number of new cases, it seems like the proportion of new cases have been slowing down since the first week of April. So that's a good news, right? But now it's been clear that this pandemic disproportionately affects minority communities. What's interesting, though, is how late in the process we started talking about the issue of inequality. It was not until the beginning of April, first sort of a major article came out April 6th. So now news media started highlighting the issue. As of yesterday, there were 527 deaths recorded in the Cook County Medical Examiners database, and 51% of COVID-related deaths in Cook County are Black, 42% were white. In Chicago, African Americans make up 63% of COVID death, and whites 32%. So how do we understand this apparent racial disparities in a seemingly sort of a natural disaster, right? So I have to tell you the background story. So one of the reasons why I got so deeply involved in the current pandemic is that I teach social vulnerability class this semester, right? So in this class, we use hazard data to model vulnerability and its effect on disaster exposure and outcomes. So for example, we look at hurricane and Chicago heat wave data, and we turned our attention to COVID-19 and social vulnerability very early on because of the nature of the class. So I recruited many of my current and former students, and they've been just incredible, amazingly active in this effort. Students are currently tracking nursing homes, prison transmission, racial disparities, low-wage workers, and also policy tracking. So Dorothy Murphy is an EPI-MPH student, and she's one of my students taking social vulnerability class currently. Shelley Hoover, our grant manager, it's been incredibly helpful, and she's managing our daily case maps. So I really thank all my students. All right, so what do we mean by vulnerability? You know, vulnerability in the context of social vulnerability research is a concept and an aggregate measure of human welfare that integrates environmental, social, economic, and political exposure to a range of potential harmful distress. So vulnerability is a key concept in understanding risk and outcomes of exposure to hazards. And it combines biophysical vulnerability, which are physical characteristics of hazard and environment, and social vulnerability to determine an overall place vulnerability. So more specifically, social vulnerability looks at social, economic, and political characteristics that shape community capacity to deal with response and cope with and recover from hazard and natural disasters. I'll say that vulnerability is socially constructed. It constitutes of history, social, and economic meanings and processes and practices. Especially we focus on geographical distribution of risk, hazard, and vulnerability. So I will say that we are indeed living in risk society. What I mean by that is that social institutions like social structure produces and reproduces social inequality, which results in the spatially distinct distribution of wealth and privilege. And we understand that there is a significant interaction between nature and society. Structural factors contribute to disaster exposure and outcomes. So natural disasters are really not natural, right? So um, why do we see spatial clusters of COVID-related death in certain areas? So it is due to existing spatial stratification, right? So it includes spatial concentration of poverty, social exclusion, and racial segregation. And the result of it is health inequality and clusters of risk factors. Because it's structural, we see clusters of vulnerability in all disasters. For example, Chicago heat wave, we saw racial disparity in 1995. In 2005, we saw same racial inequality aftermath of Hurricane Katrina and Hurricane Maria in 2017, and now COVID-19. So how do we measure social vulnerability and risk factors? So social vulnerability index is used. Social vulnerability index includes social demographic factors. I'm using the US Census, American Community Health Survey. For this study, I use 5-year estimates between 2014 and 2018, which include percent poverty, less than high school education, female-headed household with children, median household income, and the employment ratio. I looked at service workers, care workers, percent of those people who don't have cars and other things, but for now we're going to use these 6 variables just so you know that usually social vulnerability index include racial competition, but I pulled out that racial competition because I'm interested in sort of independent effects of race on COVID-related death. Risk factor score include comorbidities. I'm using Chicago Health Atlas and IDPH county level hospitalization rates. This is one issue that I want to talk to you more about, the lack of detailed information on health outcomes. So it includes the rate of heart-related death, stroke death, percent asthma, hypertension, diabetes, obesity, and smoking. Like I said, racial competition, I'm paying attention to percent Black in particular, but I'm looking at percent white and percent Hispanics. Okay, so here's the county level distribution of cases and death. As you can see, the majority of events are clustered in Cook County and some in the down south, right? So for confirmed cases now, cases are available by zip code, but it's basically showing sort of the similar clusters by county, right? But one thing that I want to say is that although the majority of cases are clustered in Cook County, but if you can see outside of county also have a lot of cases, including Kankakee down here, Will County, and Lake County. also saw increased cases. And we see cases increasing in down south. Let me see. So mainly Peoria, Champaign, and also southwest side of Illinois also saw increase in cases and death. So here's the social vulnerability index distribution. We can go down to census tract level for social vulnerability index just because we are using census tract level US Census data, but okay. And then here's the risk factor. The problem with that is that in Illinois, beyond Cook County, there's no data available to construct risk factors. I was lucky actually to find county level comorbidity data, but you all know the limitation of using a higher level, larger unit of analysis at the county level, right? So there's a greater variance within a county. So this county level data can't really tell us, sort of more granular information. So, at this point, we don't have data to really dig deeper into all the community areas in Illinois because of the lack of data beyond Cook County. So for now, let's just focus on Cook County and Chicago. So the goal is to use Cook County and Chicago data to sort of model the effect of social vulnerability and risk factor on COVID death. And then we can actually zoom out to Illinois to figure out how we can actually prioritize our effort, right? So here you can see confirmed cases and number of deaths. Not only Chicago, particularly west side and south side, especially if you look at the death cases, south side of Chicago is highly affected. And I will say we need to pay attention to, south of Chicago, Cook County, because we tend to, focus on Chicago only, but this effect actually spilled out to south of Chicago, Cook County. And this, you can see more clearly if you look at the death cases. Okay, so I was able to get the actual death recorded in the Cook County Medical Examiner's Office data. So the map on the left shows all COVID-related deaths in Cook County. And then the map on the right, I highlighted red for African-American deaths. Clearly, predominantly Black communities on the west and particularly south side, experiencing clusters of deaths. So let's just zoom into Chicago. As you can see, highly clustered African-American death on the south side and the west side. And I was just looking at this map last night and I'm like, okay, this is almost sort of reflective of those dot density maps for racial competition. And so even COVID-related death actually reflects how our society, our city is racially segregated. So again, to highlight, highly clustered death on the south side. So why is that? So, like I already said, COVID-19, you could think about this as a natural disaster, actually produces highly racialized outcomes. I already told you that natural disasters are not really natural. And I will argue that it is because of existing inequalities that are spatially clustered. So here's the separate maps for the comorbidity. So I'm showing you the map of the heart-related death rates and obesity, percent hypertension and smoking in Chicago. Risk factors for COVID death, comorbidities are highly concentrated on the west and south side of Chicago, which, map you ever see, it's got pretty much the same sort of pattern. So as a result, if you construct the composite risk factor score, you see the spatial clusters on the west and the south side Chicago, and you see similar patterns for the social vulnerability index here. So here's the side-by-side sort of maps looking at social vulnerability index, risk score, and percent Blacks. Predominantly Black communities in Chicago were disproportionately affected by both social vulnerability as well as health health disparities. But I just want to, sort of tell you a little bit of, of social vulnerability outside of Chicago. We saw death clusters outside of Chicago, south of Chicago, Cook County, and you can see here social vulnerability. Sort of higher social vulnerability in these outskirts, south side of Chicago. Again, this actually tells you we need to pay attention to and include Cook as a whole rather than thinking about Chicago. So here you can see that's in Cook County, south side of Cook County also see increased COVID-related death. Okay, so here's a simple sort of correlation matrix. Percent Black would significantly associated with social vulnerability index and risk score and the death rate right here. On the other hand, if you look at percent white actually is negatively associated with vulnerability, risk, and death. But interestingly, for percent Hispanics, even though there's no relationship between percent Hispanic and social vulnerability index and risk score, death rate actually is lower for Hispanic, predominantly Hispanic communities. All right, so what explains the increased COVID death in the African American community? I'm just showing you here the total effects from a simple structural equation model I ran like 1 a.m. last night. So risk factor scores and percent Blacks have significant direct effect on the death rate. Social vulnerability index effects on the death rates predominantly through the risk score, and even controlling for social vulnerability index and risk factor, percent Black was still significantly associated with an increased COVID death rate, which implies that beyond social vulnerability and risk and health risk, percent Black segregation implies something else. We know what those are, right? So we can talk more about that. So just one more thing that I want to show you, given what I just presented to you, testing is going to be increasingly important when we plan to reopen our economy and going back to normal life, but testing currently is extremely limited. So here's the map of, I'm looking at just U of I MySquare drive-through testing. As you can see, you know, compared to the map on the right, those are death cases, death cases. We need to better target communities for testing. Good news is that, okay, here's the axis. These are our U of I outpatient clinics, the MySquare Health Centers. So I just heard yesterday that we are going to open up another drive-through testing site on the South Shore community area. This too, I will have to say that data-driven. So we were able to show there's a lot of death and clustered cases in South Shore, and then we have a Pilsen clinic currently working. And then this morning I heard that Cicero MySquare is going to also do the drive-through that testing. All right, so I think I presented everything, but I just want to say, I agree to this talk because, you know, I think this is a good opportunity to think about the role of data and data science in emergency response, and also at the same time, there's a severe problem accessing reliable data. So we will need to sort of start thinking about a long-term data and data science capabilities for the current, you know, COVID crisis, but you know, but also thinking about future public health responses to emergency events. So the last thing that I want to say is that although my students been amazing, you know, I need help, right? You know, people like you dealing, you know, working with data, we need to get together and provide better evidence, right? So I'm assuming you guys are the you know, the best audience to ask to participate in the emergency response currently. And thank you, and I will be very happy to actually talk to you individually if there's anything we can collaborate. So thank you.
Thank you, Sage. That was fantastic. So I'm going to do a short presentation following Sage's presentation. If you have questions for Sage, you can ask it at the end. So I'll start my presentation, though it's very difficult to follow Sage's fantastic presentation. Oops. Can you see my screen?
Yep.
Okay. Thank you. So thanks all of you for attending this. So I'm going to focus primarily on modeling COVID-19 cases. Similar thing can be done for the deaths, but I haven't looked at this. This is also very preliminary work. And I want to acknowledge that when I was first trying to learn some of the models, Shoumoj Shahu, who is a PhD student, helped me quite a bit in understanding the model. And I also gained a lot of insight from various discussion with Dean Giles, Ron Herschel, and of course, Sage. So I'm going to focus on the COVID-19 cases, and this is a map that I did a while back. It's on the School of Public Health website, which shows the time lapse spatially of how the number of cases increased spatially over the United States. So this is a county level resolution showing the number of cases as it started from the Seattle area primarily, and then into the West Coast, and then started towards the East Coast and kind of spread all over the United States. So for the similar map for the Illinois, looking at the timeline of the COVID-19 detected cases. So as Sage was mentioning it, it started, the early cases were in the Cook County area, and then gradually it spread to every single county in Illinois. If we look at the county level counts of cumulative number of cases, and here I used, instead of daily counts, I used a window. So we see that on March 1st, there were 3 cases in Cook County, and that's the only county with cases. And then as we progressed, the number of cases spread into the different counties. So right now, Cook County is the one with the maximum number of cases, followed by Lake and Will, and then DuPage. So primarily the counties surrounding the Chicagoland area. And as Sage mentioned, there are cases in the Champaign area and some counties further down south. There are also some interesting dynamics. For example, Will County had fewer number of cases to begin with compared to, for example, DuPage, but gradually the number of cases increased more in Will County. So if we look at Illinois as a whole, then this is looking at not the cumulative number of cases, but the daily count of new detected cases over time. So there were a few new cases between March 1st and March 15th, and then the number of new cases count started increasing rapidly. And we see some stabilization around here in the number of new cases count. So this is for all of Illinois together. If we look at the same at the different county level, and here I looked at the 4 top counties, the ones with the highest number of cases, the 4 top ones. So then Cook County is very similar to Illinois. Whereas, and Lake also is similar, though the number of cases, the first case started later in the Lake County. And here are Will and DuPage County, which are somewhat different. There are a lot more fluctuations, and the rate of increase is not that rapid also. Well, in Will County is less rapid, and DuPage is showing some slope. Compared to Illinois, this is the number of cases in US, and here I'm looking at starting from March 1st. The first case in US was on January 21st. But if we look at starting from March 1st, again, we see that there is a rapid rise starting from March 15th, and it's a very sharp rise. And it has stabilized somewhere starting around April, beginning or a few days in April. So in terms of modeling the number of cases, and here I have to get into some of the modeling that's going on into some notations. So the popular model, the model that's primarily being used in the literature for modeling the number of cases is the SIR model, which is an existing model in the infectious diseases, which is modeled in terms of the three components: the number of susceptible individuals, the number infected, and the number who are removed or recovered. And together, these three components make up the overall population. And the SIR model describes the transition from the susceptible to infectious and the transition from infectious to recovered using some differential equations. So the main idea of the model is to break down the population into these three components and look at over time how these three components are changing. So the main interest is in the number of infections, which is IT, how that's changing over time. These are the differential equations which are used for modeling in the modeling of the SIR model. These are nonlinear, these are a system of three nonlinear differential equations. The closed form solution for these equations have been found quite recently, but approximate or numerical solutions to this are known for quite some time. So this models things in continuous time. So one of the takeaway that I get from the SIR model is in terms of this equation, which tells us about the new infections. So the concept of the SIR model is that the number of new infections depends on the number infected at that time. So the number of, if more people are infected, then the number of infections will be higher. And then the number of susceptibles at the time. So if there are more susceptibles, then the number of infections will be higher. So the number of infections, new infections, depends on the product of the number of infected, the number currently infected, and the number of susceptibles. And that's what this equation says. And the transition rate depends on the number currently infected. And this transition from susceptible to infection depends on the model parameter beta. So this is what governs how the model is going to evolve over time. So I fit a slightly different model, which is not a continuous time model, but I rather model it as day by day or as a discrete time model. And being a biostatistician, I bring in some distributions. Instead of being a deterministic model, I bring in a more distribution-based stochastic model. So I model the number of infections, which is a count as a Poisson distribution. And the Poisson distribution has this parameter lambda t. And then I take the idea from the SIR model, and I model this parameter lambda t just like it's done in the SIR model as a parameter beta times the number of susceptibles and the number infected. So the one change I make is in the SIR model, this parameter beta is fixed in time. I allow this beta to be time varying. So this is the model I have used, and it also includes some other components. So this describes the number of new infections, and the model also has other components for describing the number of susceptibles and the number are getting removed. So there are some issues about fitting these models because I am modeling this in terms of new infections, but we don't observe the number of new infections. We observe the number of which tested positive. So we observe the number of positive cases. And there is quite a lot of discussion about the literature about non-ascertainment, which means the cases which are asymptomatic or the mild cases, they are not getting tested, so they are not being detected. So we are not, the number of positives is not accounting for those infections. And some of there are various estimates of the ascertainment rate in the literature. I am using a rate of 50%. So for example, this publication in this article in medRxiv reports that the non-ascertainment rate could be as high as 59%. So I'm using a more conservative rate of about 50%. And this other article is reporting that if we are just trying to estimate the rate of asymptomatic cases, then that can be 20.6%, and the range could be between 20.6% to 40%. So even only the rate of asymptomatic cases can be as high as 39.9%. So the other complication in the model is in terms of incubation time. For example, the literature estimates that the incubation time is about 5 days. So this one reports an incubation time of median incubation time of 5.1 days with an interval between 4.5 to 5.8 days. So the cases which are getting tested and being detected, they are being detected after the incubation time. So if we want to look at what is the actual time of infection, we have to go back in time. So you have to go back T minus the incubation time. So the model that I fit, I incorporate this incubation time, we go back by incubation time. And I also try to account for the non-ascertainment rate. So how do I model the removal from the RT part? So I assume that those who are getting tested, those who are testing positive, they are getting quarantined. So they are being removed from the list of susceptibles because they are being quarantined. So everyone who tests positive are being quarantined. I also assume that those who are infected but not tested positive, so the non-ascertained cases, I assume that they are being removed after 14 days. So they are no longer infectious after 14 days from the time of infection. And I used some model for modeling beta T. I used two different models. The one that I'm going to show are using based on a spline modeling. And I will skip this since this is kind of getting late. I did some work on this before, and I'm kind of using some ideas from there. One of the issues that shows up in this plot is that when we do this kind of modeling, it's difficult to model what happens towards the end. So we can, for example, here the same data can be modeled this way or it can be modeled this way because it's the modeling the tail is sometimes quite sensitive. So let's look at some data. So if we look at the Illinois data and try to estimate this function beta T based on the Illinois data, so this is the transmission, the time varying contact transmission rate. But this is what we see. So the beginning, there is a lot of noise. Beginning part is hard to estimate. But if we see from here, we see that there is a spike around May 14th or 15th. And then the rate has been gradually going down, the rate of contact transmission. This is a crude estimate of the beta T function using a day-by-day calculation. Using my model, I smooth it. So this is how the model fits a smooth curve to that to that noisy crude estimate. So the line model fit is coming from here. This is also showing the shaded area shows a 95% spread because I fit this repeatedly for 1,000 times, and it's showing you the different 1,000 fits from the spread of those different fits. So the curve, if we go beyond the data, then this is what the curve is forecasting. So any kind of prediction that I do is based on this part of the curve. And the forecast is very strongly going to depend how I model the tail of this, because that's how we are going to forecast. So if I use this curve and do the forecast, then this is how the forecast look like. The 10-day ahead forecast looks like based on what we have observed so far. Again, I want to point out that this is very, the forecast is coming from this model. So it's sensitive to the model assumptions and how we are modeling the tail of the curve. I did a model validation. So here I only use data up to April 10th. And using data up to April 10th, I tried to predict the next 5 days to see if the prediction matches with what the actual data are. So I use data up to here, and then dashed line is the prediction, and then the spread is the spread of the prediction. And then the solid blue line is what we actually observed for those 5 days. So if we do this for Cook County instead of all of Illinois, then this is how the crude estimate of the beta function looks like, and this is the model-based estimate. And if we do the prediction for the number of cases, we see a picture similar to Illinois. So based on the tail end of our estimate of the curve, this is what we are predicting. These are for the different counties. So we did similar prediction for the Lake County. And DuPage, Will County and DuPage County. And we see somewhat similar predictions from all these models. If we look at all the other counties, so instead of, I excluded the Cook, DuPage, Will, and Lake County, and look at all the remaining counties of Illinois, then this is how the beta function for those other counties look like. So the prediction, the cases started much later in these counties, and this is how the prediction looks like for the number of cases going forward. And for this is the similar fit for the overall US data. Again, I want to mention that these predictions are based on a model. And as I pointed out, it's very sensitive to how we model the tail of the curve. So I will stop here. And if you have questions for Sage or I, we'll be happy to take those questions.
Hi, can you hear me?
Yes.
Hi, I'm also very interested in SIR model. It is basically based on solving a bunch of ordinary differential equations. I might work on modeling the effect of respiratory protective devices on transmission. Well, it uses a lot of assumptions. My model is gonna use a lot of assumptions, like hand hygiene, social distancing measures, compliance rate, difference, protective devices like high or low filtration masks or surgical masks. There are assumptions about droplet size, pathogens per droplet, recovery rate, breathing rate, etc. My question to you, Sanjib, I mean, everyone I know is using this SOAR model, but how much faith do you have in this? You are probably using fourth order Range-Kutta method, right, in solving differential equations?
So I did not use the exact SIR model. I used a discrete time model where I modeled just one aspect of it.
I see. You just used a subset, one aspect of SOAR model.
Yes, I didn't use the differential equation model.
I see, okay. And Sage, are you there?
Yes.
Sage?
Yes.
Well, I also listened to your talk very carefully, and I enjoyed both parts. In terms of disparities, I think we will better understand disparity issues when better data are collected. So far, this virus, so far infections are infections affected big cities mostly. But if and when it spreads out to rural parts where population is predominantly white, like Idaho, Montana, Utah, or South Dakota, I think we will better understand disparity issues, right?
Yep. And I already see different patterns in terms of risk factors in southern Illinois, predominantly white communities. So their risk factors and social vulnerability index sort of behave differently. So I think it's important that you mentioned that when we model or try to understand infection and death patterns, we need to actually start thinking about sort of high dense cities and then rural areas separately.
Well, I mean, transmission rate should be different across rural and urban parts. Also, effect of poverty should be different, I believe, because it's all about access to healthcare and proximity among people.
Can I just tell you, not only that, poverty behaves differently in rural white areas compared to the effect of poverty in highly segregated cities. So that too, right? Not only just poverty per se, but the type of effect that poverty has on health outcomes.
Well, I mean, there are many important factors and they all interact, like poverty, social demographic characteristics, lifestyle, right? Urban versus rural settings, underlying diseases, health, access to healthcare, etc. And I mean, what is affecting what? To me, it's always been a mystery. I mean, I'm really interested in this disparity research.
Yeah, so in terms of disparity, can I just add one more thing? What's really alarming is what's happening in correctional settings, okay? So the infection, COVID transmission rate is close to 10% in state-built prison, for example. That's just 10, 15 times higher than the general population. So that's another sort of disparity issue. And think about this. Prisons are in rural areas and the prison staff work there, but they actually live in these community areas and they're going in and out of correctional settings. So it's not just like the sort of natural sort of distribution and transmission, but because we actually decided as a society to put in institutions, the buildings, physical buildings in these areas. So it's not just the people who are locked up in there, but the circulation, between community and those facilities through staff working there is incredible. So the Cook County Jail and overall sort of prison buildings, actually the number of infection cases and are increasing faster than the general population, as you imagine. But the thing is that that I got this sort of inventory, like PPEs and gloves and things, and how the IDOC is distributing those materials in relation to the number of confirmed cases in jails, prisons. There's no relationship whatsoever, which means that it's just like ad hoc, just doing it, but not like targeting. So that's another thing that I'm sort of concerned about.
Sage, if you were to mention three biggest factors in terms of disparities, what would you say? A couple of biggest factors.
So like I said, social vulnerability mainly actually get at poverty, but like I showed you, race effect is another big, sort of independent effect. And I think the third one I would say is it's all clustered. So it's not poverty affecting it directly, independently, but there's this sort of interaction effect where when you have highly segregated poverty area combined, we usually say it's a above and beyond, sort of this is the interaction effect that creating sort of qualitative different social environment. So we can't think about this as a sort of a poverty separately and race separately.
Okay, thank you.
Sage, could I ask a question? This is Ron Hershow.
Yeah.
In the risk factor score on your maps, was age one of the risk factors in that?
So that's a caveat. I looked at the percent of people over 65. It didn't work. Like my model sort of messed up. In part, it's because I think the more I think about it, elderly communities, right, are in a way sort of insulated in a way that's not really directly being affected by sort of the circulation of vulnerability and risk. So for example, older rural white communities are not directly affected so far. We do know, like one of my students actually mapped nursing homes and sort of elderly homes, and we now see a lot more cases transmission in these facilities, but in the general population, age distribution wasn't really a strong predictor.
Yeah. I'm thinking more in terms of the death data, though. It seems like age would have to be strongly predictive in the death data. And I'm wondering if, given that the risk factor score mainly pertains to comorbidities and not age, or exclusively pertains to comorbidities and not age, whether you've looked at the African American death rates. I guess my overweening question is, are African Americans dying younger of COVID-19 than other racial ethnic groups?
That's absolutely a very important question. At this point, I have not looked at it. So I can quickly look at the average age of African Americans who are dying versus whites. So I can get back to you on that maybe this afternoon.
Okay, great. Thank you.
Hi, Sage, it's Lee.
Hi.
Hi. I think Ron's question was more can be answered using individual level data. Your the analysis, if I understood it correctly, was using zip code data, correct?
No, for death, actually, I do have actual address and individual information for Cook.
Hmm. Yeah, then there is a way to do
Yep.
both individual and including the racial,
Yep.
the clusters of the geographic.
Exactly. Yes.
So I saw the last slides of your presentation. You titled it as a total effect. Are you doing some kind of mediation hypothesis kind of thing?
Well, I just did a quick structural equation model, so I can actually tease out direct and indirect effects. So I just presented for the sake of timing, time, just presented a total effect. But like I said, social vulnerability effect mainly works through risk factor and death.
Mm. Yeah, I was just wondering your analysis scheme, like your conceptual model, was it kind of a mediation kind of conceptual model?
Yes.
Yeah.
Yes.
Okay. Yeah, that's what I thought.
Other questions?
So I have a question. A lot of people want this presentation, yours and mine. Is there any way we can actually send out to everyone?
We can probably host, like combine it or put it on box and then send the link.
Sounds
Yes.
good.
So it's going to the dean's office as soon as this is done and we stop recording. As far as, it's going to be too big to email. So I think when they have it posted to the website or something, we can just update everyone. I can set it out to the same listserv saying that, it's been posted.
Sanjib, one last question. In your model, you use Poisson model, right? Part of it is Poisson.
I modeled the new cases, new infections as Poisson.
Yeah, well, given the nature of problem, do you think using a more complicated count model would improve things, or it'll have minimal effect? Like negative binomial or generalized Poisson?
So there are multiple other papers. One looking at the COVID-19 cases in China, and there is an earlier paper in Annals of Applied Statistics looking at modeling influenza. What they have done is they have looked at the proportion rather than the actual count.
Mm-hmm.
And they modeled those proportions. One of them used a beta distribution to model the proportion.
Mm-hmm.
So there are other models that people have used. I tried with the beta model and I wasn't very happy with the way they were modeling it.
Mm-hmm.
When I tried it, it was not giving good answers.
Mm-hmm.
But I didn't try the negative binomial primarily because we had to do some of this. Well, I've been struggling with this for the last 3 weeks, but more recently I just have to came out. I needed something that is simple. But the other thing is that there are too many kind of random things. So I wanted to keep the less variability in the model.
I see. So your feeling says using a more complicated modeling technique for the count data won't improve things much, right?
No, I did not try it, so I don't know if it will improve it or not improve it. I am I'm probably less happy with how I'm handling the incubation time. I would like to handle that in a better way, and how I'm handling the non-ascertainment. That only a certain proportion of people are getting ascertained. I would like to also handle that in a better way. And then the third one will be to modeling changing the Poisson to something else.
Nice. Thank you.
Vasu, I have a quick comment for you, and then I have a question for Sage. The comment for Dr. Basu is that the test results are coming with a lag. Some test results are rapid, which could be like related to some certain type of test. And some other tests are taking like, initially they were taking like 1 week time. And right now, maybe they're a little bit more rapid test results. So so your forecasting for the current time could be like, it looked a little bit for Illinois state data, it was over forecasting, right? If I remember correctly, it was a little bit, your forecasting was a little bit over forecasting, and the current test results are just a current, and I think in a couple of days, maybe they would get updated. So that was my comment.
Yes, I agree. So I only have aggregated count over the county. So I don't know which ones are which one have gone through a longer testing period and which one has gone through a shorter quick test. Maybe that has changed over the time. Maybe earlier ones were taking longer, but I have not incorporated that into account. I only incorporated the incubation time.
Okay. My comment for Sage is that initially there was a lot of misinformation, particularly in African American community. Sage, could you comment on that?
Yeah, so, that's still the problem. I am working with community outreach people currently, but, first of all, the buses on the south side are jam-packed every day.
Right.
And people still hustling, people congregate on the street, and a lot of people actually talk about, Black people don't get this, right? But that's one of the reasons that we're not communicating correctly is that the media keep talking about, oh, comorbidity is important. What the hell is a comorbidity, right? So people start talking about, are you taking hypertension medication? Then you're high risk, right? So there's a very sort of the messaging so far has been really not accessible, right? So people started actually, taking different approaches. So we are actually getting out on the street, distributing information with a packet of masks, bandana, and then the sort of short messaging, not something from CDC that hard to understand. I can't even understand. So there was this really difficulty in terms of pushing out right messaging that could get at people like us, on the street daily, people not like healthcare providers. So there was that mismatch. And the other thing is that it's not just messaging. Even though you know what to do, your life condition is such that you have to take the bus, you have to go to work, you're living in like highly crowded apartment or something. It's difficult to do social distancing.
Hi, Sage. This is Chetri Mitchell. I just wanted to add to your comment, and I'm glad you brought the last part up because I met with my community partner today, and he mentioned that people understand in the Black community that this is something significant and that social distancing should occur, but a lot of the same people that are driving these buses, that are essential workers at grocery stores, they also tend to be lower income or African American, and they don't have the protective equipment that they need. I know New York has started the mandatory face mask, and I know that I think Illinois, the Governor Pritzker is thinking about the same thing, but where is access to these masks? Where or access to testing sites like you've mentioned. So I think there has been misinformation across the board for all groups. Because at first it was like, it doesn't affect children, it only affects those 65 and older, but that was incorrect. But I also just think that what you've talked about in the beginning, you know, structural racism and these social vulnerabilities just keep certain populations at greater risk, regardless of what information is put out there. So I just want to
Yeah,
add that.
thank you for the comment. Yeah, that's absolutely true. Yes, thank you.
Just a comment, this is Ron Hershow. I know that David Jimenez and COIP are sort of planning to up their outreach to community members in many of these communities. And, you know, it's just very challenging how you do outreach in the era of social distancing. The kind of street outreach that COIP does is very almost intimate, you know, it's very face-to-face. And they're struggling with some of the issues about how do you actually do it? Do you stand 6 feet away from people while you're trying to message to them? And it just becomes a very challenging endeavor. I was wondering if you had any thoughts about that, Sage.
Well, I worry about that too, and I also worry about so for example, U of I, we got some money from Blue Cross Blue Shield to distribute food and things like that, and because of that, I was asked to recruit students. First thing that I asked was, are my students actually have to go out on the street? That's really a challenge, really. Like, I don't have an answer to that, you know, Ron, you know, as you know, but yeah, I mean, I don't know. You know, I've been worrying about that, even though like I try to recruit students to send them out, distribute food and things and masks and things like that. But also at the same time, I feel really concerned. Our outreach workers and COIP, David and everyone. Yeah, it's troubling.
Any other questions? Well, then I want to thank Sage for giving such a great presentation on such a short notice and for threatening to do whatever to me last night, last evening.
Thank you, but you will pay.
But
Thank you so much.
Thank you both. It was great. Thank you very, very much.
Thank you. Have a nice weekend.
You too. Everyone have a good
Thank you.
weekend.
Thanks, Sanjeev. Thanks, Sage.
Thank you.
Thanks.